ऊपर ध्यान तो कुछ नहीं बनाना, निकल गया सिंगल मामा में ऊपर में लगे छोड़ी।
Alka ma'am, you
Admin
can
right?
mute.
Admin right?
एकदम
हाँ, मैं भी कुछ खा रहा हूँ, तो इनको भी खिला।
ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः
Alka ma'am, you
विनायक
can
नमो नमः
Admin right?
गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
There are no patient. Night webinars are disturbance. And Radha will listen. Yes.
Ashini, you can start. Are you there?
Yes, ma'am. Good evening, ma'am. Sorry, ma'am.
You start.
Yes, ma'am.
Next.
Hello,
Ma'am, can we
doctor.
have the anthem?
Yeah. Yes, put it. Pallavi. Anthem. Yeah. Yes.
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
खाली है तो बैठ जा।
So today we have two persons, that is Dr. M.C. Patel sir and Dr. Poonam Dikshit as the chairpersons for today's program. I welcome Dr. M.C. Patel. He has been FOXy uniform concerns have been done by him, and he's a very senior person who has handled a lot of medical legal training and support for the members. Vice President of FOXy in 2018 and our chairperson Ethics and Medical Legal Committee, and he has conducted ASUG 2017 as an organizing secretary, and he has got so many credentials to him, and he is extensively involved in community service. He is the honorary surgeon in Red Cross Bank, collected more than 1,000 iPads, and then he always the services in the medical camps in Northeast states under Dhanvantari program is it is known to everybody. And in the Government of India, he has been a PNDT NIM of Government of India, Gujarat PNDT State Supervisory Board member and National Managing Committee, and professional leadership in President AOGS and IMA Ahmedabad President, National President of NMO, and organizing chairperson of Vivekanand NMO conference in 2018. And I welcome Dr. MC Patel. And the next person is Dr. Poonam Dikshit. She is a clinical director and senior consultant obstetrician from Poonam Surgical and Maternity Hospital, Patna, E-Zone coordinator for Vaginal Surgery Committee, president of Society of Vaginal Surgeons of India, Bihar and Jharkhand chapter, fellow representative of AICC RCOG E-Zone, and she's an MRCOG examiner, member advisory board committee of ICOG, and then contribution to books and Foxy focus are numerous. She has special interest in vaginal surgery, minimal access surgery, education and training, and high risk pregnancy. Over to Dr. Poonam and Dr. MC Patel sir to take over.
Thank you.
Pallavi, share the CV of Madam Alcare Endometriosis. Yeah.
Thank you. Thank you very much, Endometriosis Society of India. I can see Dr. P.K. Mitra there and Professor Ramani Devi. Thank you for giving me this opportunity. Ramani, can I go ahead with introducing?
Yes, you go ahead with the introduction.
Yes.
It's
Really, I feel very honored to be introducing none other than Professor Alcare Endometriosis, who is currently at Paras Hospital, Gurugram, and we all know what an excellent endoscopic surgeon she is. And her CV will take very long. So I'll just put in the salient features that she had an excellent tenure as President Foxy in 2016. She has also been President Jessie from 2011, and she's still continuing. And editor Asian Journal of Obstetrics and Gynecological Practice from 1999 to 2017. Her academic excellence reflects she being on editorial board in 9 journals. She was a co-chair in FIGO Menstrual Disorder Committee 2016 and 18. Government of India awarded her with Padma Shri for her excellent services in 2015. And as an excellent teacher, she got B.C. Roy National Award as an eminent medical teacher in 2007. So I think there is no better speaker than Madam on a topic which is enigmatic, but it is clinically very important, and that is scar endometriosis. Over to you, Madam Kriplani.
Thank you so much, Dr. Poonam, for your kind words. A very good afternoon to everyone. First of all, I must acknowledge my dear friend Ramini, who is queen of endometriosis. The way when I was president, she made guidelines. Everybody
I think Madam's network is problem. Dr. MC Patel is here, sir.
Yes.
Yes.
Am I audible?
Yes, sir. Yes, madam, you are audible.
Yeah, so
Okay,
I
go
was
ahead.
telling about Ramni that she is queen of endometriosis. When I was president, she made guidelines, and so many people rang up and they were benefited, and they said they are best of the guidelines. So Ramini, your work on endometriosis is really great, and nobody can say you know. But at that same time, I would like to appreciate Dr. P. Das Mahapatra, who is the father figure. And when endometriosis was not so common, he was, he started society and work. And Dr. Mitra, who is carrying the legacy. It's a pleasure seeing my dear chairpersons, respected chairpersons, Dr. MC Patel, whom I hold with very high regard because of the different field he is working and the way Dr. Patel is working for so many years relentlessly and helping all Foxy members in sorting medico-legal problems. Poonam Dikshit is from Patna and she is so active in academics. So thank you all for the invitation. I think I will start my lecture. What Ramni gave me topic, it is rare, but I'm very happy whatever Ramni gives me. So my topic today is scar endometriosis. My slides are seen here?
No, madam, you have to share.
We'll just take a minute. Share. Now can you see?
Yes, madam, make it. Yes, fine. Super.
Okay. So we all keep seeing cases of scar endometriosis, may not be so commonly. It's not moving. Yeah, perfect. So we all know that's why we are sitting here and Ramni spending so much of time propagating knowledge on endometriosis. We all know what it is, but it is becoming more and more common a problem. So the scar endometriosis. So what is scar endometriosis? This is a kind of extrapelvic endometriosis where there is functional endometrial tissue in surgical scar site. And most common is after cesarean section. So it's not that it's only in the cesarean scar. Extrapelvic can be in the urinary tract, lungs, thoracic region, intestinal tract, cutaneous, and it can be de novo also. That means without any surgery. And this is the classification we all follow. And it has got its own place, like here, so that we are supposed to document and properly put it in its place in classification of endometriosis. And people have given new classifications for scar endometriosis just to make it, speaking the same language and to stratify. So, if the size, to score it, what symptoms it is causing, and these are the points. I think it is for a practitioner not much of use, but very important point is why some people have scar endometriosis. It can occur without patient suffering from endometriosis. It is called de novo kind of congenital. So this slide explains that there are these metaplastic changes of urachal remnants, and many times I have seen scar endometriosis at umbilicus. It is a kind of nodule. Every period she comes with pain, and then we can. It's a very easy diagnosis if proper history is taken. So this is kind of de novo congenital, but iatrogenic where we have done some surgical intervention and endometrial cells are implanted. Most common being after cesarean. We have operated it episiotomy scar, trocar site in laparoscopic surgeries, after hysterectomies, amniocentesis needle tract, and after appendicectomy. So all these surgery following which the cells get implanted on the abdominal wall and scar endometriosis occurs. So why it happens is we will discuss in a minute, but scars where it is common is where there is a small incision and against like you are pulling the tissue and there is less space so that more of the endometrium is in contact with the abdominal wall. So phalansteal scar incidence is more because now it's no more that big surgeons give big incisions. We big surgeons now give small incisions and smaller the incision and there is higher chance of implantation of these cells and hysterotomy. You know why? Because hysterotomy endometrium is more viable. It is in the second trimester. So it is seen after hysterotomy scar endometriosis in the scar is commoner than with higher BMI, higher parity and hereditary predisposition. So these are some of the causes for development of scar endometriosis. Now for a clinician, the next question is a patient comes to you, how she presents? Because first you have to diagnose, then you will manage and treat. So patient presents usual history is before period and in period. There is pain, there is swelling, which increases in size. So usually cyclical, but in later stages can be non-cyclical pain, increasing size, discoloration, and what is the differential diagnosis? So that not every nodule at the scar is scar endometriosis. You have to differentiate hernia, hematoma, chronic abscess. These are differential diagnoses one has to keep in mind. And what is the way to confirm your diagnosis for a clinician? Not every patient presents in a classical way. Otherwise, with good history and examination, you can make a diagnosis, but then ultrasound, MRI, if required, CA1 to 5, FNSC, especially when you have a doubt. it is hematoma or abscess. These all help in clinching correct diagnosis. So we know what is scar endometriosis, we know how it presents, we know how we diagnose it, and then comes
Yes.
the management, how to manage a patient who presents with scar endometriosis. We have very many options: medical, surgical, new or non-surgical. All these drugs, which we all use for managing endometriosis, have been used, and I'll just showing in brief the literature. Then surgery is the definite solution. Then these newer, especially this microwave, radio frequency, sclerotherapy, these are also newer kits in the block. So this is a patient of umbilical endometriosis. We happened to operate. She had intra-abdominal endometriosis, which was removed in routine laparoscopy. Then there was a nodule at the umbilicus, and it was so easy. We gave the incision and the scar in a way so that we went just by the side of the trocar, so that the same incision can be used to remove the nodule in the abdominal wall, and the closure will be only one, like the trocar side as well as the endometrioma excision were made one, and then one incision. So one can see, and when you cut open this nodule after removing it, you will often see there is collection and functional endometrium like tissue in it. So many drugs have been tried with variable results. Now progesterone we use only Dinogas because of its advantages. Then for pain relief, but lesion size is not affected. Pain relief may be there. Overall, surgery is the more effective way than all these drugs. GnRH agonist, it's a very strong drug. The problem is the time you give it is okay. Again, patient usually have recurrence of symptoms. Now we have antagonist, and there are studies in the literature for various period of time, especially when the patient doesn't want surgery or is waiting. These different drugs have been tried with variable success. But usual story is the time you give the drug, patient is okay. Once you stop, the pain recurs after some time. It's not a permanent solution. So these are the drugs now. Elagolix, Reluvis is there. We are using all. So the next question is, when you will give medical therapy for scar endometriosis? As we said, surgery is the definite answer, but people keep giving medical. So the situation where medical is advisable is when you have operated, it has failure of previous surgery. So patient is no longer for another surgery, or she was all right. She again developed in another area, recurrent scar endometriosis. Or a patient is not a candidate for surgery, she may be surgically unfit. Or when all failure of all other medical management occurs, some patients they don't accept surgery, they want to try medicines. So after failed medical therapy, these are the common indications for medical therapy in cases of scar endometriosis. Then it's a very common thing to ask whether pre-op you should be given or post-op. So for pre-op, some people give to facilitate surgery, but in my mind, it leads to reduction in the nodule size, and it becomes difficult sometimes to locate the nodule. So I personally don't believe in giving them suppressive therapy, because nowadays we have such good imaging, you can always, mark. And the best time to operate is premenstrual, when the patient comes, that size has increased and there is pain, so that your chances of missing out the lesion are least. And post-op therapy to improve surgical outcome, if one is doubt that the correct complete marginal, margins have not been removed, or for secondary prevention, patient has 2 3 surgeries, now she's okay, so it is apprehension and you put her. Many times it happens that the patient is put up for pelvic endometriosis, at the same time scar is taken care. So all these are indications, and how long in the post-op one should give, if at all you are giving, up to 1.5 to 2 years is the general recommendation. So definite is surgical management. Hormonal treatment is for failure of therapy or when the patient doesn't accept surgery. This is another case. I would like to give a very large experience of removing the scar endometrioma. You start doing something, and I don't know from where cases keep pouring in. So many times we have seen in a case of previous cesarean, the uterus is stuck to the anterior abdominal wall and there is a big nodule protruding there. Once or twice it happened with us that it was associated and it was in direct continuity with the body of the endometrial cavity. So the patient was having periods and it was directly going. So it's very important to delineate how deep is the scar, whether rectus sheath is involved, rectus muscle is involved, or is it in continuity with the uterine musculature, or is there any direct connection with the endometrial cavity? Usually it is not. Usually they are up to rectus sheath, but sometimes muscle is also involved. And see, you cut the specimen. Try to remove the complete nodule and cut the specimen and see there is collection and fibrosis inside. So once you ensure complete removal of the nodule, usually recurrence is least. Another question is, when will you put mesh? Many times what happens, the small we dissect and remove nicely. I tell you, it's very important our MRI person puts a mark, or we call ultrasonologist in the OT and put a needle on ultrasound guidance so that you give very small incision and complete excision of the nodule is possible after properly locating the nodule. So these are the surgical finer advices, and this is complete removal is important. Then there's a very nice paper in the literature that they reviewed 68 cases of cesarean scar endometriosis, and they reported after surgery 95% cure. So, and they also reported that medical therapy usually had recurrence, and it is very logical because once you stop drugs, what may be the complication that the every patient asks? Doctor, you are removing my scar endometriosis. Am I likely to have any complication or I will be okay? So there can always be infection. There can be hernia formation. So if you cannot close it without tension, we put mesh in the scar to reduce incidence of future hernia in it. Adhesions may be there, and well, some patients may have some nerves are damaged and they have numbness or pain. Recurrence is always a risk, and risk of malignancy, although very rare, but clear cell is cancer has been reported. I have never come across, must have done hundreds, but I have never seen. But everything may happen, and you have to counsel the patient. Rarely there may be cancer in it, as it happens in endometriosis. Now, another very important question is: we discuss medical, all the drugs, we discuss surgery, ensure complete removal of the will be greeted with good cure. But what are the newer management options? And they are very important. Radio frequency ablation, percutaneous cryoablation, microwave ablation nowadays many people are doing for adenomyosis. If in our experience, these things have very variable results. It depends on the person who is doing it, what kind of machine they have. And we surgeons will agree. We think that it is surgical. It's so easy to remove the lesion surgically, and nobody wants to have recurrence. With these modalities, since it is not complete excision cannot be ensured, variable recurrences have been reported in the literature. But these are for recurrent cases. I think they are good modalities, especially microwave now is available in many centers. So after discussing how they present, how to diagnose, how best to manage, surgical is the best, but medical has its own place, and how to get reduce complications, like if it is a big scar, if area is big, then put a mesh, prevent infection. But very, very important point is how can you prevent scar endometriosis? 100% nobody can prevent, but if we are careful, we can definitely reduce incidence of scar endometriosis. So I think this is a very, very important slide. What all we can do. Whenever we are removing clear surgical margin of 1 centimeter. If you, those who are doing these surgeries will agree with me, you come to know whether you are removing whole nodule or sometimes it is bad recurrent case, lot of fibrosis, then you are not sure that the whole lesion is out, then there is higher risk of recurrence. Then in normal case, like you have done a cesarean, thoroughly wash the abdomen. If you are doing laparoscopy, thoroughly wash the abdomen while trocars are still in place. After, most common is after cesarean. So it's very important that that there is one practice, old practice. People take a sponge, put inside the uterus, and in order to remove all the placental bits, they like mopping kind of thing is done of the endometrial cavity. I think this practice should be discouraged because this viable decidua gets implanted in the abdominal wall, especially when the incision is small. You are rubbing against the incision and cells, chances of endometrial viable cells getting implanted on the scar are higher. Then they derive gradually blood supply from the surrounding vessels, neovascularization, and the lesion starts increasing. And it sometimes it is such a painful situation, patients come and tell, do anything, I want to get rid of this pain. So it's very important, thoroughly wash the abdomen and extend breastfeeding period to delay menstruation. I think it's a very good way that the breastfeeding should be prolonged. And avoid mopping the endometrial cavity. Nice saline lavage at the end. Try not to rub against the abdominal wall, the instruments and your mop, and separate needle should be used for closing the cesarean scar and closing the abdominal wall. Carefully flush the before subcutaneous closure. Nice saline lavage. In laparoscopy, never remove the specimen where it is in direct touch with the uh, abdominal wall. So always inside the bag or inside 10 mm trocar, no endometrial tissue should be ever been directly touched with the abdominal wall. Otherwise, patient will come after a few months at the place of the port site. There will be scar endometrioma, which is not very rare. So a surgeon has to be very prevention minded, taking care not to let endometriotic tissue or decidua touch in the abdominal wall in laparoscopy or in open surgeries. That goes a long way in reducing the incidence of scar endometriosis. So we have to teach our youngsters to keep that point very well in mind, because nowadays it's the time for smaller scars and we don't have to rub or mop against the scar. Thank you very much for the patient hearing. If there is any question, it will be a pleasure to listen.
Madam, that was an excellent presentation. Poonam Madam and MC Patel sir, for your comments.
Patel
Yes.
sir, don't
Hello,
ask me
Ram-
medical questions.
So
You are
excellent,
of
excellent,
medical
Kriplani madam, as usual. And you have very specifically said that recurrence is known in this type of management. So at the time of counseling, we should be very clear. We cannot give guarantee. We can
This is
give
from a
guarantee.
super medical legal person.
Yes, yes.
Very important. Once there is
We
recurrence, they keep coming and crying and holding you responsible. So
yes,
we have to tell. When patient asks me, Madam, मैं ठीक तो हो जाऊंगी, I say nothing is 100% in this world.
yes.
So,
So we
very
can give
important.
guarantee of our best efforts, but not of result.
Very right, sir.
Yes,
Very right point.
we can explain that what is the problem actually, what we are going to do, and which are the possibility having recurrence in the same condition. So if we have explained very properly and nicely, and even in discharge card also we have to write that very sentence. It was explained that very the remote possibility of recurrence to avoid all future legal consequences.
And
Thank you,
surgeon
madam.
should never be overconfident.
Yes,
Yes.
You will
exactly.
think you have done a wonderful job, and the God sends the patient, that you should not be overconfident. So
Oh, yes. Oh,
Patel
yes.
sir has given a very, very important thing. Always tell them it's not 100%. There is some
Yes.
risk of recurrence.
So, coming to second topic.
No, sir.
Sir, before that, sir,
Ah.
madam, I come, madam.
My chairperson, Patel sir, whom I
Yes.
hold with very high regard, because for decades I see him selflessly working and giving medical legal advice. Today also he gave this lovely advice that document it. It's very important, I think. Poonam ji, I have come so many times to Patna on your, and what to say of Dr. Ramini, my queen of endometriosis.
Madam, I have one question for you.
Sure.
Question for you. See, scar endometriosis, many a times I have seen associated bladder endometriosis also.
Very good. Bladder actually, Ramni, I have seen number of times that direct contact, there is cesarean history. The fundus of the uterus is stuck, especially the isthmocele area when there is isthmocele.
You're not audible, madam. You're not audible.
In practice, I have seen, am I audible?
Yes, now you are audible, madam.
Yes. So in practice, I have seen, apart from bladder endometriosis, many a times when there is isthmocele in previous scar and there is thinning of the wall, it is in direct continuity with the endometrial cavity. And in that situation, we have to do associated laparoscopy, detach those adhesions. And as you said, bladder endometriosis may also occur in that area because they all are in vicinity.
Okay. Then, do you think that by doing proper layer closure during endometriosis, 2-layer closure, and then visceral and parietal peritoneum approximation, can we prevent this?
I am very happy for this point. When I was professor at All India Institute, this coronary trial started with Dr. J.B. Sharma. And they said you need not suture it in layers, you just leave it. In 48 hours, peritoneum regrows. But I have a very different opinion, seeing so many patients, because in the same institution, I believe in properly closing it in layers, especially cesarean scar in 2 layers. Otherwise, isthmocele incidence is high. If you don't close the peritoneum, there is higher incidence of adhesion that leads to lower segment getting stuck to the abdominal wall, uterus getting retroverted, high incidence of isthmocele and endometriosis. So I personally believe that we should suture in layers properly. Our seniors were doing it very correct way. We were not seeing so many scar endometriosis. We were not seeing so many ischemoses. I sometimes you call me and I will give such a nice video presentation of all these horrible problems of ischemocele which we keep facing nowadays.
Yes, madam. Thank you. I just wanted it out of your mouth because I am also for proper layer closure, 2-layer closure, closure of peritoneum, everything, because that's your right.
Yes, can I have
Yes, madam. Yes. Poonam, madam, you want to add something?
Yes. I just wanted to ask that you said sclerotherapy. Do you have any personal experience of it? Have you used it, Madam Kriplani?
It started with, putting tetracycline, ovarian endometrioma. Dr. Poonam, I personally don't believe in these half-hearted works. I am an aggressive surgeon. I believe in cleaning properly, doing complete nice surgery. I have seen abscesses after these sclerotherapies. I have seen ischemias. These are, personally, I don't have good experience with these things.
Even I thought that they are of not.
What is your opinion, Ramini?
Madam, you are not audible again.
What is your opinion on
She's asking, what is your opinion?
I think surgery is the ideal thing for scar endometriosis because medical management can only be temporary and all the recent HIFU, microwave ablation, everything is in the preliminary stage. Unless we do...
Preliminary and recurrence is very high.
Recurrence is quite high. Quite high.
And surgery is so simple and so safe.
And what
medical treatment for very small scar and
Dr. Poonam, it is not the size. I have seen very, very small scar endometrioma giving so many symptoms to patients.
okay, we can go ahead.
And
I
even
think
a
thank
big
you
one
very
may
much
not
for
be
this
more
Ramni?
important than the size is her
Ah.
symptoms and problems.
Okay. Thank you, madam. Thank you for sparing your time.
Thank you for
Pleasure to
this
see you.
invitation. All my favorite people are here. Thank you so much. It's a pleasure.
Excellent.
Thank you.
Thank you.
Thank you. Thank you, madam.
Thank you, Sarji. Thank you.
Please stop sharing. Yes, fine, madam. So coming to second topic, urogenital endometriosis. And just discussion was going on about bladder endometriosis. And as we know, as far as urogenital endometriosis part is concerned, bladder is the common organ. Almost in 85% of the total cases of urogenital endometriosis, bladder is the target, and then ureter, urethra. So to deal with the subject, let us invite Dr. Meera Raghavan, madam. She is a senior consultant, urogynecologist, and robotic surgeon, proctor and trainer, Hugo Ras Robotic Platform, board certified lifestyle medicine physician, convener TNFOG certificate course in Urogynec, National Board Specialist Committee member, treasurer, SOFC, TN chapter, and there are so many accolades in her credit. So without wasting much of your time, straightway to the subject, Meera Raghavan, madam, stage is yours.
Thank you, sir. Thanks for the wonderful and warm, kind introduction. Thanks, Ramani ma'am, for making me part of this elite congregation as well. Please allow me to share my PowerPoint.
Yes, you can share.
So, as MC Patel sir has already mentioned, urogenital endometriosis, the bulk of the problem is by bladder endometriosis. And urinary tract involvement happens in about 1 to 2% of endometriosis itself. But nowadays, because of, as clearly explained by Professor Alcare madam, that it is now more evident in the form of either scar endometriosis or what we call the niche or the isthmocele, we get to see more bladder endometriosis as well as deep infiltrating endometriosis. It can be either a primary or secondary disease, either from spread of the peritoneum, the serosa, the detrusor, or the mucosal lesions, but most lesions are intramural in nature. It takes a lot of clinical acumen to first categorize this as bladder endometriosis. Majority of the patients will present with UTI-like symptoms, but the red flag sign is hematuria and persistent dysuria in spite of treatment for so-called urinary tract infection symptoms. So all that is burning is not UTI. It's the first dogmatic understanding we need to get to be able to clinch the diagnosis of bladder endometrioma. It has cyclical dysuria, frequency, urgency, suprapubic pain, and cyclical hematuria may not be present in the first place, but severe bladder pain can be associated. We all need to do a urine analysis and culture. If there is hematuria, kindly do urinary cytology to rule out carcinoma in situ. But if it presents blood cells, definitely a transvaginal ultrasound with the associated sliding sign, and endometrioma can be easily visualized in a proper 3D ultrasound itself. MRI is mainly done for mapping and surgical planning, but with a very good 3D ultrasound, most of these are visible on a 3D ultrasound itself. The medical management can be tried in patients as far as they do not have any significant symptoms such as hematuria. We can try the progestogens, but beware of the fact that majority of the progestogens can give rise to progesterone resistance. We now have GnRH antagonists, which are promising oral agents. may be tried in patients with less of symptoms than hematuria, or we're not considering surgery at this point of time, and for symptom control as well. Surgical management will involve shaving for the superficial lesions, which we can do it with the transurethric resection with the help of our urology colleague. But partial cystectomy still forms the gold standard because, as I mentioned earlier, if majority of the lesions are intramural in nature, just mucosal scraping or shaving of the superficial lesions alone will not be curative in nature and is prone for recurrence. At the end of the day, we have already mentioned this point that we cannot guarantee complete cure, but we need to take every possible measure and document the same from medical legal point of view to be able to be showing and demonstrating the evidence that we have taken every single measure to prevent recurrence. We might need it to combine with endoscopic procedures, either robotic platform or laparoscopy, to deal with the deep infiltrating endometriosis, or resection or dissection of the bladder away from the uterus, because majority of them can be associated with a niche or a scar endometriosis from the top down, and this will need a proper separation. And to also prevent fistulization, we might need to do in omental interposition between the bladder scar as well as the uterine scar. So surgical outcomes, complete excision has very favorable outcome to extent of 4 in 5 women showing complete symptom improvement. And we always follow it with a 2-layer bladder closure, which is watertight in nature, further tested by integrity either with methylene blue or saline, and it has a low recurrence rate. I generally tend to put them on a medical management following the surgical procedure, preferably with a dirogest molecule or with a GnRH antagonist currently, so that recurrence is completely prevented. I usually try to continue that for about 3 to 6 months, so acts as an adjuvant therapy. If we quote that deep infiltrating endometriosis is a recurrent medical disease, and even after surgery, they will warrant adjuvant medical therapy. So will be the case for urogenital endometriosis. Would like to know the experts' comments after the presentation on this particular thing as well. Just to show how dense bladder adhesions can be, this is a Hugo Ross assisted bladder dissection, where there is significant adhesion due to deep infiltrating endometriosis from the uterine point of view, and we do a head-on approach with the bladder. This is post-surgical scraping of the bladder endometrioma, which was there, and we're making sure everything is released from the anterior surface of the uterus so as to free this portion, so further endometriomas do not occur, because it's direct communication between the scar as well as the bladder. So take-home messages as far as the bladder endometrioma is concerned: think of bladder endometriosis as cyclical urinary symptoms. RTVS imaging, especially with 3D improvisation, is the key to clinch the diagnosis, and partial cystectomy provides symptomatic durable relief. Moving on to ureteric endometriosis, why this particularly matters? Because deep infiltrating endometriosis is increasing. As a lifestyle medicine physician, I also incorporate lifestyle changes in the form of anti-inflammatory diets, as well as reduction in weight to reduce the estrogen burden, especially fat reduction, and also giving them dietary advice on cutting down on animal protein and processed foods to avoid the microplastic load, which in turn can aggravate the estrogen excess in our body. And it's mandatory for us to give these tips because these patients are known for recurrence. Unless certain lifestyle changes are maintained, they might come back with symptoms. So ureter involvement is often silent. It's ureter which remains silent, but kidney which dies a death. So this has to be borne in mind as care practitioners, and this has a risk of irreversible renal damage, and delayed diagnosis is quite common. So how common is this? Up to 1% of overall endometriosis can present with ureteric endometriosis. 1 in 5 of deep infiltrating endometriosis because of extrinsic scar compression can lead on to ureteric endometriosis. 20% of the ureteric endometriosis are because of intrinsic mucosal involvement as well. And the left side is more common than the right side. So we can imagine how where all the ureteric is prone otherwise for compression, because as it runs along the pelvic brim, along the lateral pelvic wall, and passes under the uterine artery and closer to the uterosacral ligament. All these places, because running along the lateral pelvic wall as it entering the pelvic brim, if the ovarian fossa is tethered due to endometriosis, it can get involved and cause hydronephrosis. As it comes along the uterine artery, where extensive deep infiltrating endometriosis can be present due to the broad ligament endometriosis, this can get involved. Uterosacral is known to be the most important seat for endometriosis. If they get tethered and puckered, this is another place where the ureter can be involved extensively because of the endometriosis. We also need to understand that the ureter is very sensitive to vascular insult because of high risk of devascularization, and it is important to understand the segmental vascularity of the ureter when we perform our ureterolysis during the dissection of the pelvis as well. So pathophysiology is mainly by chronic inflammation, which is why I mentioned about pro-anti-inflammatory diets, and fibrosis and compression, progressively narrowing with the silent obstruction causing backflow, hydroureter, and hydronephrosis. And we already mentioned that 1 in 5 can be due to extrinsic compression, but intrinsic pathology will need resection of that segment of the ureter which is narrowed with reanastomosis as well. So what can be the clinical presentation? It's often flank pain, which is pretty late because it's the kidney which is borne the brunt, dysmenorrhea and dyspareunia, which is symptomatic of the endometriosis as well. A majority of the patients, it's an incidental finding when they come for these kind of problems. If we remember the fact that 40% or more of large endometriomas can be associated with deep infiltrating endometriosis, is mandatory for us to make sure the upper tracts are normal, because those are the cases in which silent ureteric compression can be ongoing and lead on to hydronephrosis as well. So cortical thinning of the hydronephrotic kidney can happen with silent loss of renal function. None of the renal parameters will show till about 90% of the kidney is lost, and that will only manifest if both kidneys are affected. So we need to regularly image, and the most important parameters which we look for the kidney are the AP diameter of the renal pelvis and the cortical thickness, which should be monitored if there is a suspicion. And if they get any abnormal, that will be an indication for intervention surgically immediately. And presentation of urosepsis is also known, and that has to be taken into account. So we do transvaginal ultrasound, which is 3D, and MRI pelvis in deep infiltrating endometriosis. As I mentioned, renal imaging is mandatory. If you're in doubt, we also assess the functional capacity of the kidney by doing a renogram in the form of a DTPA and find out if there is excretion defect and if there is any damage in the function. So we've also mentioned about the features which are to be seen in the ultrasound diagnosis in the form of either a bladder endometrioma alongside with a parametrial nodule, which can be seen in hydronephrosis. And these are visible pretty much in a good 3D ultrasound as well. MRI further maps the area, the deep infiltrating endometriosis, especially in the form of nodules. This is very important because of the multidisciplinary way in which we plan a thorough surgery for endometriosis. People who perform surgical treatment for endometriosis should be made aware of the fact that the first surgery should be the best surgery, and most excision of the endometriosis and clearance of the problem gives the best chance for cure and symptomatic relief and prevention of recurrence as well. So we need to map these nodules perfectly so we understand whether there is rectovaginal involvement, whether there is ureteric involvement or bladder involvement, and perform the surgery appropriately. So this is just to show the parametrial nodule and the involvement possibly of the ureter, with showing hydronephrosis on the other side. So I've also mentioned assessing the split renal function by DTPA and for pre-surgical planning. we generally take that if the renal function is deteriorated less than 15%, that kidney will be deemed as a non-functioning kidney. But anything more than that, we need to give the benefit of doubt and perform the surgery, and that tends to improve the kidney function. So we need to prevent as much as kidney damage and perform nephron-saving surgery, and that will be the way forward for any deep infiltrating endometriosis with a possible ureteric compression and involvement. So preserving renal function and to relieve the obstruction by a multidisciplinary approach will be the key to the management of ureteric involvement in urogenital endometriosis. Is there a role of medical management at all? If at all, it will be for prevention of recurrence and not for the cure of the patient. It does not reverse obstruction reliably. In fact, when patients are put on GnRH agonists, what we see, there is a further scarring because these endometriosis heal by cicatrization or scarring or puckering and tethering, which can in fact worsen the extrinsic compression of the ureter, further causing rapid deterioration of cortical nephrons, leading on to permanent kidney loss. So medical management is not a reliable method if we are going to cure the obstruction, and should not be resorted to in a patient presented with hydronephrosis. So when do we resort to surgery? If there is hydronephrosis, that itself is an indication, and we perform either a segmental resection if there's an intrinsic compression, and a ureterostomy or a uretero directly entering to the bladder, what we call neocystostomy. This can also be done. This is just to show a video where we can see the hydroureter, where there is a segmental involvement of the ureter, which is completely puckered, and we then anastomose the ureteric surfaces, the mucosa, to be giving us a normal ureteric caliber, which is not obstructed. And if does not happen with ureterolysis, just relieving the extrinsic obstruction, we need to cut off that segment which is adherent and then perform the anastomosis. We use a 2 or a 3 OPDS to do the surgery, and that will help us. So 3D magnification of the robotic platform helps us have a proper, precise dissection, better suturing, and lesser blood loss. And the most important technical aspects of this surgery is identify ureter at the pelvic brim, avoid too much stripping because that is the way the vessels enter, and use minimal energy sources and use sharp dissection as well. Thermal injury can lead on to complications, and this can be because of significant injury and stripping of the peritoneum of the ureter, and that can lead on to urinary leak, stricture recurrence, and fistula. We always keep a DJ stent for 4 to 6 weeks and remove the stents after 6 weeks' time, and we perform a renal ultrasound at 3 months and make sure there is no cortical thinning or hydronephrosis, and renogram if indicated if we find the AP diameter still quite dilated. So the important take-home message is always image the kidneys and deep infiltrating endometriosis empirically, because silent obstruction is common and intrinsic disease needs resection. So the ureter does not complain, but the kidney is the one which bears the brunt of it silently and is destroyed. So what are the guideline recommendations for management of urogenital endometriosis? ESHRE, evaluate an urinary tract in all posterior compartmental DIE, and always refer the complex cases to expert center with greater magnitude of this particular problem, and use your professional colleagues and have a multidisciplinary approach. The EAU suggests functional imaging in obstruction is mandatory, surgical reconstruction whenever indicated. Surgery is primary, medication is adjunct treatment. Ureterolysis for extrinsic compression and non-obstructive compression, whereas you have to resect and reimplant if there is an intrinsic or severe obstruction. always done with full excision with a multidisciplinary input, stent pre-op, and monitor renal function and renal imaging in the post-op. The AAGL always recommends advanced lab skills for ureterolysis and sidewall. It is not something a novice or a trainee would do. And we need to have performed minimum 100 cases to prevent the injury to less than 1%. Always important to involve your urology colleagues. Ureterolysis, as I mentioned earlier, more than 80% will be enough if they are extrinsic compression. Same as what we discussed, pre-op stent and post-op GnRH. Pre-op GnRH only worsens the obstruction. This is just a busy slide, unfortunately, for the possible management of urogenital endometriosis put together. And I'm happy to take comments, inputs, as well as suggestions and questions. Thank you for the opportunity.
Patel, sir? Yeah.
Yes, excellent, madam. As usual, you have nicely covered the topic, considering robotic platform and this laparoscopy also. And as you have mentioned again, in this urogenital endometriosis also, we cannot give a guarantee because again, recurrence is known in this situation also. So nicely covered the subject. Thank you, madam.
Thank you, sir. I would like to add one more point to this, sir. We should not forget one more coexistent condition called bladder pain syndrome. Being a urogynecologist, it is known to coexist in more than 40% of endometriosis. And patients present with bladder symptoms such as pain, urgency, and frequency. There's usually no hematuria, but these patients also get bounced back and forth as treatment of UTI and never get better. So if a subset of patients have bladder symptoms, always do a concurrent cystoscopy while doing a laparohysteroscopy. Or the other way around, if I'm investigating bladder symptoms and patient has chronic pelvic pain or symptoms of endometriosis, always plan it with laparoscopy because we will not be surprised if we find endometriosis. And treatment has to go hand in hand because adenomyosis, endometriosis, bladder pain syndrome are known as the terrible triplets. So we need to bear that in mind as well. So sorry, I forgot to mention that while I was presenting.
Poonam madam, any comments? I think she's not there.
Ma'am, Poonam ma'am gone for an emergency case, ma'am.
Okay. So Meera, I think it is worth screening for kidneys
always
when we see any endometrioma. That
always.
is the message I would like to give
Thank
today
you,
because within the last 3 months, we had 3 young girls, unmarried girls, who came with loss of renal function.
Yeah.
So, simple thing, they have been diagnosed to have endometriosis, endometrioma, put on medical management, but lost to follow. They are taken for 3 months, 6 months, that's all. So, but ultimately when they reached me, they had unilateral severe non-functioning kidney with hydronephrosis.
Yeah.
Okay. So that is one thing. And then you have insisted upon telling that it is a disease medically not to be managed because fibrosis worsens the condition.
Yes, ma'am.
That is that's an important point that we have to give.
All of us have burnt our fingers in one case or other by, falsely being reassured by the symptom relief, but we can potentially lose the kidney.
Kidney, yes, that is one important. So in general, my view is all extragenital endometriosis have to be handled surgically. Only ovarian endometrioma or superficial lesions can be handled like medically. Even DIA, when you are starting the patient on medical management, be careful that underlying structural loss can be there. So should not be always the same. Sir, Mitra sir, any opinion from you?
Large endometriomas, rectal symptoms, bladder symptoms, DIE, always image extensively. Try to treat surgically and then put on medical management.
Correct. And again, medical management, you said for 3 months to 6 months. I
Minimum.
slightly minimum, but the longest period is ideal thing is to maintain for 2 years. The reason
Minimum,
is-
it will go long.
so 2 years minimum, because the de novo lesions start occurring. If it starts, it will appear.
Very true.
It will take 2 years. Or if you want to have a chronic suppression, better you maintain for 2 years. So
Minimum,
that is the
minimum.
time limit.
Yes.
2 years we need to maintain. Even if you are doing post-hysterectomy status for endometriosis, I think always better to put the patient on long-term suppressive therapy for minimum of 12 to 24 months.
Yes.
Preventive.
And the post-menopausal endometriosis are the one where we might need to involve surgically, because
Yes.
these are more prone for
Malignancy
kidney
also.
loss and malignancy.
Malignancy.
Yeah. Yes.
Thank you, Meera. Thank you for
Thank you for the
short
lovely
and-
opportunity.
Okay. Harshini, I think it is next my turn.
Yes. So coming to topic number 3, endometriosis and malignancy. So as we know, endometriosis is estrogen dependent benign condition, but it has a chances of transformation into malignancy. Of course, it is very rare, 0.5% to 1% or so. But in this situation, usually they are related to ovarian malignancy mainly. So to deal with the subject, may I please invite Dr. Ramani Devi. Ramani Devi is President TNFOG 2024, National Vice President of FOXI in 2020, International Advisory Board Member of Fertility
Sir, I think
Society
we
of
can stop it, sir. We are
Bangladesh,
running short of time.
ICOG Governing Council Member 2018 to 20, Managing Director, Ramakrishna Medical Center LLP and
Sir, I
Janani
think that is
Fertility
enough, sir.
Center.
Enough.
So yes, but one line I would like to mention, Ramani Devi is good host. Whenever I have visited Trichy, she had taken utmost care of mine to make my visit of Trichy very comfortable and memorable. Thank you, Ramani Devi, for the same.
Thank you. Thank you,
And
sir.
now, stage is yours.
Thank you, sir. I'll start sharing my screen. Can you see my screen?
Oh yes, it is seen.
Okay. So generally I have been talking about endometriosis and infertility, but for a change, I am going to talk something about the endometriosis associated malignancy and what are the genetic and pathological insights into this endometriosis related neoplasia. So when you look into the history, Sampson in 1927 and Scott in 1953, they had given some diagnostic criteria to say whether this lesion is arising from endometriosis. For that, the evidence of endometriosis and cancer should be in the same ovary. Comparable histology to endometrium. Exclude the possibility of metastatic tumor, because we do get a lot of metastatic tumors in the ovary also, like the Krukenbergs. Then histopathological proof of transition from benign endometriosis to malignancy. That means in the same ovary, we have the benign endometrioma that is shifting more towards the atypical and then towards malignancy. This was in 1988, La Grenard and Silverberg identified what appeared to be the precursor lesion that is called as atypical ovarian endometrioma. That is endometrioma, atypical ovarian endometrioma, then it becomes malignant. So the associated malignancy is more common in ovarian. 80% of the lesions are endometriosis associated ovarian cancer is originating from ovary, and still we can have something from the extra ovarian like abdominal wall scar endo can turn into malignant, and small intestine and colonic, sigmoid, rectovaginal septum and pleura. So the common malignancy that is seen in endometriosis ovarian carcinoma is clear cell carcinoma, and especially you can see this tumor lesion, that is the clear cell lesion that is arising from that of the cesarean section scar. Then now let us see what is the compare endometriosis versus malignancy. Endometriosis, all of us know that it is a chronic inflammatory, hormone dependent, benign gynecological lesion that is characterized by the presence of endometrial tissue outside the uterus. Endometriosis is common, benign, and it leads to morbidity. See, I would rather say the patient who has presented with malignancy, they die because of some reason. But whereas endometriosis is one disease which will increase the morbidity without causing mortality. But endometriosis related malignancy is quite rare, but it can lead to mortality. Then let us come, what is the incidence of endometriosis associated cancer is, it's quite often less than 1%, 0.3 to 0.8. And most common thing is ovarian cancer. So now, clear cell carcinoma, taking into consideration the histopathological examination, clear cell carcinoma is 40% coexistent with endometriosis. Next comes the endometrioid carcinoma, that is 23% coexistent with endometriosis, and very rarely bought, that is seromucinous borderline ovarian tumors can happen. Endometriosis, it increases the risk of clear cell carcinoma by 3-fold, endometrioid and low-grade serous carcinoma by 2-fold, and there is definitely no increase in the risk of high-grade serous carcinoma in patients having or mucinous carcinoma. Then, what are the subtypes? So here, there is increased risk with ovarian endometrioma. Like endometrial carcinoma, endometriosis associated ovarian carcinoma commonly arises from the ovarian endometrioma, and there is no increased risk with peritoneal and deep infiltrative endometriosis. That is the main thing we have to understand. So peritoneal endometriosis and dye will not lead to malignancy, but in dye also we can say if it is involving the colonic region, you can get clear cell carcinoma of the colon. But the most common site is ovarian endometrioma. So now let us see how malignancy occurs in endometriosis. That is the theory number 1 is it goes from phase of ovarian endometrioma, then it leads intermediate spaces that atypical endometriomas. From that we can develop EAOC. So that there are, of course, we have so many other genetic backgrounds like genetic aberration, epigenetic factors, hyperlipidism, which is always pro-inflammatory, neoangiogenesis, immune dysregulation, inflammation, and oxidative stress. All these things will be a common cause between malignancy and endometriosis. Again, now they have shown an importance to this Aridia gene mutation, and the scholars from Yale University, they have found out this mutation is one important reason for the onset of endometriosis and clear cell carcinoma, and they have found out in this EAOC. Then again, PIK3CA, P10 mutation, cross mutation are all the mutations which can lead to EAOC. Then the pathogenesis theory, that is second theory is endometrium, we know that it is a source of endometrial glands and the stroma which have got oncogenic mutation. They only reflex outside. So to say here, you can see this endometrial glandular tissue is being retrograde spill. It will lead to endometrial cyst, and then this endometrial cells can undergo under the influence of gene mutation or any initiator. It can lead to endometrial associated ovarian carcinoma. Here again, we have to give importance to Aridia, PIK3CA, and P10 mutation, as well as loss of heterozygosity that is seen in endometriosis associated ovarian carcinoma, endometriosis, and ectopic endometrium. Then the mechanisms of gene mutations are here again this receptor tyrosine kinase that is being influenced by this Aridia mutation or cross mutation or PIK3CA mutation and P10 mutation. All these things will lead to DNA damage and repair, and it will lead to cell proliferation, cell migration, and ultimately the invasive nature of malignancy. Then again, when there is a retrograde menstruation, it can lead to tumor microenvironment under the inflammation of severe oxidative stress, metabolic reactions, and all the inflammatory things. We know interleukins, tumor necrosis alpha, prostaglandins, nuclear factor kappa B, all these things are elevated in endo, which can increase the reactive oxygen species. And based upon, along with this, the gene transcription is found to have an influence in developing EAOC. So again, now oxidative stress, pro-inflammation, then microRNA dysregulation, histone methylation, DNA methylation, and gene mutation, all these things can lead to EAOC. So that not only this DNA methylation, histone modulation, along with all the other mutation, it will finally lead to ovarian EAOC or endometriosis associated ovarian cancer. The microRNAs, certain of the microRNAs are dysregulated. Some of the microRNAs can be upregulated and some can be downregulated, and because this microRNA can once again be the reason for endometriosis associated cancer. So then they have found out in advances in genomics sequencing have led to the discovery of new gene mutations and better understanding of the function of previously identified genes and pathways associated with EAOC. That is P10 mutation, B-catenin, cross mutation, microsatellite instability, ARIDIA, and the unique role of inflammation in the development of EAOC. See, the same P10, ARIDIA, cross mutation, all these things can happen in endometrial clear cell carcinoma also. Clinically, endometrial associated ovarian carcinomas are seen in the younger age, in contrast to the ovarian carcinoma that is seen. Non-endometrioid carcinomas are seen in an elderly or middle age group, and generally it will be of lower stage and grade of tumor, and it is mostly confined to the site of origin, and they are more likely to be in premenopausal women when compared to other ovarian cancers. So the distribution of, again, the histological types, they differ from general population. Usually they have a very good prognosis with a better survival if they are picked up in a very early stage. There is definite alteration of BCL2 gene and P53 gene in benign appearing areas of malignant endometriotic cyst when compared to benign endocyst, suggesting that alteration in the expression of two proteins may be involved in malignant transformation. See, normally there is definite suppression of BCL2 gene and the P53 that is exaggerated in both the malignant transformation. Then coming to the role of immunohistochemistry, which can pick up. So this plays a major role in investigating, understanding the transition from endometriosis to cancer. IHC helps in characterization of the tumor type, whether it is clear cell or endometrioid, assessing the expression of protein associated with malignancy, and potentially they can identify the target for therapy. So the targeted therapy for endometriosis associated ovarian carcinoma can be picked up with IHC studies. These are all the IHC key markers and the relevance: ARIDIA, BAF250A, HNF, P10, estrogen receptor, and VEGF. All these things have got variable effect in endometriosis, clear cell carcinoma, and endometrioid carcinoma. Here, ARIDIA is almost atypical, 60 to 70%. It is lost in endometriosis, clear cell, and endometrioid. And HNF1 beta is positive in 40 to 50% with endometriosis, and strong nuclear positivity is seen in clear cell, and it is found to be negative in endometrioid. Then P10 is loss observed in some cysts. Loss is common, and again in endometrioid it is common. So estrogen receptors is almost positive in endometriosis, and it is lost in clear cell carcinoma and often positive in endometrioid. So that VEGF expression is, we know that lower expression than carcinoma, elevated VEGF and high PARP1 lead to poorer survival. So this can also be used as a IHC marker, can also be used for a prognostication also. Then in endometrioid carcinoma, elevated, that is VEGF is elevated versus endometriosis. So now let us see who are the patients who are at a risk of developing endometriosis associated ovarian carcinoma. There is increased age, when the increased risk when the age of the patient is less than 30 years, long-standing endometriosis greater than 10 years, larger endometriomas, short cycles, obesity, chronic inflammation, elevated gonadotropin, family history of ovarian or breast malignancy, unopposed estrogen HRT post-hysterectomy for endometriosis. This is one important iatrogenic cause, and damaged ovarian epithelium and ethnicity. So the message is long-standing endometriosis always have a careful watch, and larger endometrioma are at a higher risk of developing EAOC. Then the protective effect is if the patient has been put on oral contraceptive pill for a greater than 10 years, or tubal ligation, or self-injectomy, hysterectomy, even without BSO, they say that it has got some protective effect. And how long does it take for the malignant transformation to occur? Not that today you see an endometrioma and tomorrow it becomes malignant, but they have found that by Japanese meta-analysis says 50% by 3 years of diagnosis, 75% by 5 years of diagnosis, and majority of them take 10 years. So EAOC were cancers to begin with and not transformation of an existing endometrioma. And the median age is around 40 years. So when to suspect malignant transformation? Whenever any endometrioma shows rapid growth during premenopausal period or during hormonal treatment in fertile age, we need to think. Then advanced stages and in very large endometriomas beyond 8 centimeters, or when they have suspicious features in ultrasound or MRI, we have to think about endometrioid carcinoma. Then again, better than CA125 is HE4 to diagnose suspect malignancy. Then the diagnosis, how do you diagnose? It is mainly by high index of suspicion, we diagnose EAOC. Then how to differentiate in transvaginal ultrasonography? See, this you can see a clear endometrioma where the walls are thickened with a low-grade echogenic areas and a ground glass appearance, and it is totally avascular. So then you see a atypical endometrioma where there is inhomogeneous echogenicity, internal septations, and then irregular margins, and then calcification, and you can see this papillary projections also. Without, sometimes it can be without blood flow, and but you have to differentiate from decidualized endometrioma, which has got a similar appearance during pregnancy, that we need to differentiate. And here, when you suspect strongly in ultrasound, you can see this multiple polypoidal things, cystic content in the presence of solid areas, and you can see the vascularity. And when the papillary projections are more than 3, or when the patient has got associated ascites, you have to think of suspicion of EAOC. Then what are the features seen? And next thing is we go to MRI. MRI malignancy in endometrioma with an enhancing mural nodule or nodules in contrast enhanced MRI images, we need to think. And then always mural nodules, when you see in an endometrioma, always you follow the patient because they are at a higher chance of developing endometriosis associated ovarian cancer. And when the endometrioma is again rapidly increase in size, and endometrioma with loss of shading in T2 weighted MR images, we need to think about malignancy. Then malignancy, can it occur in extra ovarian endometrioma? The madam has been describing that one of the complications in a scar site endometriosis is it can turn malignant. Similarly, the solid masses are masses in the cul-de-sac, pelvic floor ligaments, rectum, the vagina, or post-hysterectomy vaginal vault, bladder, and postpartum surgical scars and nerve roots, they can have malignant chain. Intermediate signal intensity in the mass on T1 and T2 weighted images, and enhancement of the mass on contrast enhanced MR images, restricted diffusion in the mass on diffusion weighted image, lymphadenopathy. Endometriosis has to be identified at MR imaging or surgery, or in the absence of knowledge about endometriosis, a history of gynecological surgery. For example, if the patient has got a hysterectomy or a cesarean section or episectomy. So MRI is a recommended protocol for endometriosis is T1 with and without fat saturation plus T2 in 3 orthogonal planes. Typical T2 shading due to repeated intracystic hemorrhage, and you can see that levels of this bleeding, it varies, the pattern varies, and high signal intensity in T1 fat saturated. If solid areas, then gadolinium contrast and subtraction imaging can be recommended. So the typical endometrioma in a typical T2 shading is due to repeated intracystic hemorrhage. You can see this, and high signal intensity for fat suppression, blood clots, and generally there is no presence of this neural nodule. So here the T2 imaging is the bladder is dark in color and endometrioma is light in color, and it is reversed in T2 imaging. Then in MRI in endometriosis associated ovarian cancer is this loss of T2 shading in T2 and modification of high intensity on T1. So here you can see this malignant lesion, and here in T2 there is contrast enhanced imaging and all this T2 shading and solid areas, and T1 high intensity, and you can see the solid areas in the dark color, and in T1 fat suppression also you can make it very clear. So this is a picture of a clear cell carcinoma arising over endometriosis in a 40-year-old infertile woman with 28 weeks of ovarian mass who presented with renal failure due to obstructive uropathy. So it is not only the question of malignancy, but also obstructive uropathy can happen in any endometrioma. What are the histological types? We have already mentioned that endometrioid and clear cell carcinomas, and they have increased risk for low-grade serous ovarian cancer. In a series of 556 patients who underwent surgery for ovarian malignancy, frequency of endometriosis was as follows, with serous and mucinous tumors 3.6 to 5.6%, and endometrioid tumors it is 26.3, and clear cell it has got 21.2. So the commonest malignancy that is associated with endometrioma is clear cell and endometrioid. Rarely other malignancy types like borderline, that is what tumors can happen, and endometrial stromal sarcoma or adenosarcoma may be seen, but they are very rare. So this is the histology of endometrioid carcinoma associated with endometriosis. You can see a lining of this malignancy as well as endometriosis in the same plane. Then how do you manage this? Management of endometriosis associated ovarian cancer is the same as that of non-endometriotic associated ovarian cancer. That is, treat the patient like a patient with ovarian cancer with a surgical staging and chemotherapy. No difference in efficacy of primary standard treatment, including cytoreductive surgery and adjuvant platinum-based chemotherapy between endometriosis associated ovarian cancer and non-EAOC has been reported. Laparotomy is always better than laparoscopy. All of us know that we don't plan laparoscopy in a patient with suspected malignancy. Then what about the management and the prognosis? Majority they present with relatively young age, early stage, more unilateral when compared to ovarian cancer that are not associated with endometriosis, and hence the prognosis is better. Endometrioid cancers can be of low grade or high grade, and clear cell carcinoma are by default high grade, and they are chemo-resistant. So the prognosis, regarding the prognosis, is relatively good prognosis, and significant better overall survival is seen in lower grade, lower stage of cancer confined only to the site of origin. And endometriosis per se does not affect the prognosis of the ovarian cancer, although there is no difference in progression-free survival between the two groups. Endometriosis associated ovarian cancer has got a better overall survival than non-endometriosis associated ovarian cancer on root analysis. So then coming to the molecular typing of endometriosis, now the concept of molecular typing of endometrial cancer and endometrioid adenocarcinoma has emerged. So that the synchronous endometrioid EC and endometrioid ovarian cancer are clonally related and originate from the endometrium. So molecular classification of TCGA is applied. Prognosis is similar to that of endometrial carcinoma subtypes. So it can be pole mutated or microsatellite instability or CN low dose or CN high. So the same thing is being applied to endometriosis associated ovarian cancer. Then again, the molecular subtypes are related with DFS, more so with clear cell carcinoma. It is similar to that of clear cell carcinoma, has got mimics a similarity with the ovarian carcinoma. Even though clear cell carcinoma are traditionally considered aggressive, pole mutant and MMRD ovarian cell carcinomas carry out a excellent prognosis. That is my other things, that is the MMRD and OECs, they presented with a poor outcome, and P53 mutant has got the worst prognosis. So traditionally we say this ovarian carcinoma or the clear cell ovarian carcinoma are aggressive, spole mutant, and MMR. That is, these things have got an excellent prognosis. So screening, is it possible? There is no benefit through screening or risk-reducing surgery as self-injectomy with or without oophorectomy in prevention of EAOC. So this, that again, we have to find out what are the other cancers associated. I've already mentioned, especially in EAE, colorectal cancer is very high. The risk of developing endometrial cancer is higher when the diagnosis is made greater than 40 years of age, and in cases of long-standing endometriosis, close monitoring is needed, and especially in women with endo and adeno, they have a high risk of colorectal cancer. Hence, the women should be counseled regarding the appropriate diet, increased fiber dietary fiber should be offered, and again, they should be offered the screening for colorectal carcinoma. Future is identification development of EAOC by microRNA assay. Overexpression of serum MIR 16, 21, and 191 has been reported in endometriosis-associated ovarian cancer and may be a promising biomarker for this. Molecular subtyping may facilitate targeted therapy. So to conclude, 80% of the endometriosis or associated cancers occur in ovary, and EAOC occurs in ovarian endometrioma, not in dye and pelvic endometriosis. There is increased risk of clear cell endometrioid and seromucinous borderline tumors and low-grade serous carcinoma. And the ovarian endometriomas, especially, they need ultrasonographic surveillance with a median age of 40 years and suspect if solid areas and mural elements with the increased vascularity are found. Interest in molecular subtyping of EAOC should be similar to endometrial cancers. Endometriosis is not precancerous condition but benign disease with a malignant potential. There is increased evidence on the role of genetic mutation in clear cell as well as endometrioid carcinoma developing from endometriosis. More evidence is needed before generalizing any mutation screening test. EAOC can be investigated using IHC to identify specific markers and understand the transition from endometriosis to malignancy. Maybe in future it may help us in management also. It can characterize the tumor type, assessing the expression of proteins, and as I said, potentially identify the targets for therapy. High index of suspicion and good pathological evaluation of the specimen are needed. Management needs to be tailored to the individual case for the best outcome. And thank you.
Thank you, Professor Ramni, for such an excellent coverage of the topic. And we should all be very careful and monitor these patients. I just had a quick question that in women over 40, you say the incidence is higher. So while offering conservative management, I think this word of counseling should be told when we offer them conservative management, because many of our patients, they will not come for follow-up, once the pain is better, they will just stay at home. What do you think?
Yes, 100%. In fact, I tell my patients with endo and adeno to come for regular follow-up, and beyond the age of 45, I advise them for a radical surgery, that is hysterectomy with a BSO. I tell them you can reduce the incidence of endometrial carcinoma, tubal carcinoma, ovarian carcinoma, and colonic.
Yes.
Plus breast, because we are all reducing the risk. They are all risk-reducing factors. So I advise them, you can get rid of this pain as well as protect yourself from so many malignancies. But even if you do the surgery, the patient has to be on 100% follow-up. That is must.
Thank you very much indeed. It was excellent, and I hope a lot of people have attended and benefited from your lecture. So over to Dr. MC Patel. We can invite our next speaker.
Yes. Next topic. As far as this endometriosis is concerned, we are discussing since long as far as surgical management is concerned, transformation of endometriosis into malignancy is concerned. But still there is a role of medical management also, particularly in recurrence after surgical management, or when surgical management is not possible for some other region, and what could be the future medical management of endometriosis. So may I please invite Dr. Pradeep Kumar Mitro to deal with the subject. He is founder and Secretary General Endometriosis Society of India, past President Bengal OBGYN Society, working on endometriosis and adenomyosis for last 23 years, organizing secretary ICE 2025, publications 17 journals and a number of books, international faculty FIGO, ACE, AOCOG, SEUD, AOFOG, etc. and past faculty University of Illinois, Chicago and USA, past faculty Uchida Hospital, Japan, visiting experimental endometriosis research fellow, UBC, Canada, and principal investigator, NHS Southern Health Foundation, UK, in 2024 to 2027. So, stage is yours, Dr. Pradeep.
One more message I would like to say. Now, Pradeep Kumar Mitra sir has been elected as the President of Endo Society of India.
Good.
Congratulations, sir.
Thank you very much for the kind words, Dr. Patel and Dr. Ravani Devi. May I sharing entire screen here? Is it visible? Is it visible? Dinesh? Is it visible?
Oh, no. No, slides are not seen, sir.
What to do? I just tested it first.
We can see you, but not the slide.
Jignesh, please help Dr. Pradeep, please.
Yes, sir. Yes, sir. You click on a share button.
Yes. Let me see what is there. There. I'm sharing. I just click the share, then
Select the first option, sir. The screen.
Chrome. Chrome tab. No. Yeah, got it.
Sir, still your sharing is not start yet, sir. Just wait a minute. It's coming. Yes, sir. Your screen is visible.
Yes, yes.
Okay. Thank you very much, everyone, for the kind words, particularly Ramani Devi and Dr. Patel. And obviously, it is a very theoretical area, but I'm going to speak today. So, a little bit of introduction. And endometriosis, as we know, it's a disease of weak and unconformed etiology. It is defined by the presence of estrogen-dependent, resistant lesions outside the uterine cavity that induces a chronic inflammatory reaction, frequently resulting in chronic pain, which is known as the endometriosis-associated pain on one side and infertility on the other side. But both of them cannot be treated simultaneously, as all of us know. And I feel it's a global epidemic, and the incidence is not 10%, which is written in most of the books. Most of the features that is primary dysmenorrhea, non-menstrual pelvic pain, and etc. are seen in more than 70% adolescent girls, out of which I found myself then 40 to 50% that landed up with endometriosis in the future. So treatment, there's no cure, we know. So the only way is to detect it at the earliest as possible, and followed by medical treatment. And surgery is very limited role. Is becoming gradually. Definitely, it has role, but its role is becoming lesser and lesser with time, and we're more uh, focused on medical management. Now, what should be the ideal management molecule? The molecule should be definitely treat the pain and have acceptable side effect profile, then should not have contraceptive effect, must not interfere with the spontaneous ovulation, fertilization, implantation of the fertilized ovum, and enhance spontaneous conception. Then it should not have any teratogenic potential, and then it prevents the development of new one endo implants to limit the need of repeat surgery, and it should be used for the long term with absolute safety profile. It should be cost effective and is easily available. But further, they should suppress the growth of already existing lesions and then prevent the complications associated with advanced endometriosis. Finally, they should be efficacious enough for all disease phenotypes, including superficial endometriomas and deep infiltrating endometriosis, ectopic endometriosis, and myopathy. Now, the big question: do we have any such drug in our van? Answer is no, a big no. Endometriosis associated pain, the mechanism and the possibility or the uh, factors which are responsible for EAP are complex and multifactorial, and it's very difficult to treat. And we all know the typical symptoms of endometriosis, which you can see on the left side. But we often ignore or we do not focus ourselves on the other problems which is associated with them, like abdominoplastic myalgia, musculofacial pain, bladder pain syndrome, irritable bowel syndrome, vulvodynia, dynia, and progressive vestibulodynia, chronic fatigue syndrome, etc., etc., and all. Now, we all know about the management with combined continuous contraceptive or contraceptive pill, two diameter. I am not going to talk about them because I'll be trying to say to you about the future, and then sorry, talking phone. Then coming to the diagnoses, it has got how many mm, provide it is modulator, it is aromatase inhibitor, it has got moderate DNA suppression effect, anti-proliferative effect, and newer thing, it is also coming up as one of the agents which can act as gut microbiome fact. Then it is also anti-angiogenic. In my presentation, I'd like to divide my presentation into 5 areas. One is the oral generic analysis, oral generic antagonist beyond elagolix. Number two, beyond oral generic antagonist. Third one, newer drugs and therapies. And fourth one, experimental therapies. And lastly, few on the ultra endometriosis researches. Now, I had the chance to work in a place, I'll come to that later, this endometriosis research lab, where they come up with a pain cycle and oral generic antagonist is there to break that pain cycle to induce uh, its effect on the sufferings of endometriosis. Now, oral generic antagonists, there are four molecules of which elagolix and relugolix. These two are only approved by US FDA, and others awaiting linjagolix and Gregolix. I'll come to that later.
Sir, your bandwidth is low, sir.
These are there. Now, the best thing We all know that the five and keeping this part intentionally because so many things to say, and you also the initial flare effect and severe hypertonis in contrast to antagonist, which is less hyperestrogenic effect. Certain information about GnRH antagonists are that. What are the uses? It is being used for moderate to severe endometriosis associated pelvic pain as a second line of treatment. One. Secondly, at the marker. Third one, heavy muscular bleeding and uterine fibroids, and last one, controlled ovarian stimulation. What are the side effects? A little bit of it, like bone loss, which may not be fully reversible. Hyperestrogenic effects are already there, like menopausal syndrome, as hot flashes, mood swing, headache, fatigue, absence of heat, and all these things. Liver health might have some adverse effects like elevation of the liver enzymes, and mental health potential for suicidal thoughts or actions, and there may be loss of libido. And about contraindications of post-pregnancy and lactation, seizures, osteoporosis, liver diseases I have also highlighted. Then those who are taking statins and certain other areas like allergy to this type of drugs like elagolix and use below the age of 18 years has not been fully evaluated. Then other areas one thing is to be kept in mind that unrecognized pregnancy might occur due to unpredicted ovulation while using elagolix, and so non-hormonal contraceptives will be used. So overall effect is like this, there is significant improvement of pain up to quality of life, and it reduces the use of opioids or alike painkillers and come to that. But the new FNU is that this I'll be showing the next slide. We all know all about elagolix and its doses, duration, and all that. I'm just not going to tell about that. But the more important thing I want to say, the lower part of the slide, that we are making a trial from our end, Endometriosis Society and US, from Miguel Michel is there from US, was State University, to use it extended elagolix therapy for 12 months or more, 200 milligrams with advac therapy is in the trial, and we also trying to give some calcium, magnesium, and vitamin D tablets along with that. These are other areas. This trial is going on. Then the second one, this one, relugolix, we do have this particular molecule in India. It is also been approved by US FDA. And this gentleman, very good friend of mine, this Charles Petalia, uh, who is who was very much instrumental in taking up relugolix for the use of in the use of endometriosis. The basic studies of Spirit 1 and Spirit 2, and it is comparable to the Prolite, and Relugolix-CT is being available today in the market as Relugolix 40 milligram with estradiol 1 milligram and non-estradiol 0.5 milligram. There are two regimes are being offered. One is continuous therapy for 12 weeks, or initial for 24 weeks, sorry, and initial regular therapy for 12 weeks, followed by continuous therapy for another 12 weeks, and its half-life is 12 to 14. So extension study up to 80 weeks or so can be made or not is under trial. So our intention is to have prolonged suppression with less side effects. Linjagolix based on it is there on a level study. It is basically being used for treatment of fibroid, management of fibroid. And Linjagolix, its indications are more or less same as that of elagolix, and it's by dosage of liaglix is 75 to 200 milligrams. It can be given for 24 weeks, and its efficacy is more than 30%. There is reduction in the dysmenorrhea and non-muscular pelvic pain, and this improvement occurs in a span of 6 weeks. In all liaglix doses, we find that this EHP, that is endometriosis health profile, there are 30 6 domains, and which have been found to get improved with liaglix. And then only 200 milligram dosages can cause improvement of 6 domains. And there are certain adverse effects, headache, BMD, the loss, which is increases, and the higher dose can achieve better control and pelvic pain and require add-back therapy like others, as I've already said. The fourth one is opicolics. Opicolics, there are many types. ASP 1701, 5 milligram OD can be given for 12 weeks. Others are OB 2109 and KLA 2109. These are under trial, very few studies are there on these molecules. Last one in this context is Degarelix, which is being used for a long term. That is being advocated. These are not yet been approved by US surveyor. So we have been talking so much on this GnRH oral antagonist, but when to think beyond that, these are the 5 areas. When we have adolescent endometriosis, secondly, mild to moderate pain. Third one, when only hypoestrogenism is not the cause of endometriosis associated pain. Fourth, neuropathic pain, when it occurs due to fibrosis and intact nerve, central sensitization, and cross sensitization. Endometriosis pain is mostly nociceptive or neuropathic pain, but nausoplastic pain in the form of peripheral, central, or cross sensitization occurs, as we know, and the only way to differentiate is quantitative sensitivity test. Now, in endometriosis, there is alteration of the nervous system physiology, and that's the reason why peripheral, central, and cross sensitization occur. There is expansion of the nociceptive field, vein morphology is changed, there is diminution of the pain, threshold inhibition of the incoming signals, there is increased increase in hypersensitivity of incoming signals, and all this to increase the nausoplastic pain. These are the 7 tests. I am not going to details of this QSP, how to differentiate. Now the area comes when this pain is unresponsive to conventional therapy. What to do? Then oral neuromodulators have got it. All the first line is to give some oral neuromodulators like amitriptyline or pregabalin, and second line is to give a combination of any of them. But another way is to go for sacral neuromodulation in the form of inferior hypogastric plexus block and electrical sacral plexus stimulation. This is how inferior hypogastric plexus block is being done. And secondly, you can see electrical sacral neuromodulation therapy over here. This one, just like pacemaker, like symptom is being placed in the second area, and electrical stimulation is being done. These are all these devices are being used for by the surgeons for bladder and bowel control, but beyond the convention of several drugs there which are not eventually approved. These are time tested off label, and then it's not approved. The newer drugs, the first one is dichloroacetate, which causes reduction of the lactate. Lactate is there in the ectopic endometrial cells, which cause it which causes the adhesion of this endometrial cells in ectopic area of the peritoneum and other cells, and this dichloroacetate blocks the lactate, and this is the very first non-hormonal and non-invasive treatment for endometriosis. And second one is the gut microbiome. We all know about it by this time. There is always a crosstalk between the microflora and endometriosis. There is no time-tested drug, but as I already said, the Danagest is one of them. It has got some role in this area, and metronidazole or salmeterol may be tried. This is a flowchart. I am not detailing this one. This shows the relationship between the gut microbiomes and the endometriosis as another separate and another completely separate chapter in this context. Then comes metformin. Its role has been tested. It modified the stroma epithelium communication. It is anti-inflammatory and anti-proliferative as well. Then cannabis and allieds, they help, or rather it has got impact in cell signaling endocannabinoid system as well as they act as inflammatory marker. They are under trial as feeding, yes. They modulate the abnormal cytokines and promote fertility potential. Few site, yes. This is from Swiss biotech. It is one non-hormonal antibody-based therapy. Then pelvic floor therapy, particularly for pelvic relaxation, it improves superficial dyspareunia and chronic pelvic pain, particularly in deep infiltrating endometriosis. Then endometriosis and other inflammatory diseases are there. They are linked together. At least 11 conditions are there, from migraine, backache, multi-site chronic pain, and irritable bowel syndrome, and so on. So the drugs, the common drugs, which are targeting those conditions might have effect on improvement of endometriosis. The newer drugs come, as you see, the SPARMs, various SARMs, selective estrogen syndrome is a very good drug, as been reported. It reduces the estrogen receptors without affecting the bone or central nervous system area. And it also reduces the size of the implants, and also it has got no impact on ovulation. Further, another one is a 16234. There, this is in the pipeline. The new one with all the good effects of biodoxyfen. Then dupastone, you all know by this time, but not that much of use. Uh, the other forms, the iloprostol and mifepristone, they reduce the early endoproliferation, and they promote apoptosis of the endometrial cells. But the better one is azoxystrobin, which has got partial progesterone agonist effect with endometrial selectivity. Another one is the Tana project, which reduces the MMP in endometriosis, apart from other effects which I've already highlighted. Then danazole. Danazole, vaginal ring, and or IUD are being used recently by various workers. Then selective COX-2 inhibitor, rofecoxib, reduces EPA endometriosis implant size, and the combination of iloprostol, dupastone, and diamide are often being used. Then, but the drug which need at present is the which would resolve the fertility, like anti-angiogenic drugs and others in the form of statins, which reduces MMP and got anti-inflammatory, anti-angiogenic, antioxidant, and causes dyslipidemia. The others are cabergoline and quinaglide. The one study is going on, and very soon one paper will be published in this context. The use of cabergoline in endometriosis. Both these drugs cause reduction of new angiogenesis, we know, by its impact on VGA and VGA-2, and also it reduces vascular permeability. It has got impact on DIE and others, particularly when hyperproliferativity is associated. The other one is the rapamycin. It is actually one antifungal drug. It is immunosuppressant, and other effects like hypoxia-inducible factor, etc. And then other drugs are rhodamycin, romidepixin, and paroxysome proliferative inhibitors like rosiglitazone or pioglitazone. These are also effective, particularly they act on circulating endothelial progenitor cells. The few other newer immunomodulators are loxolobine, intercept, and pentoxipyline. Pentoxipyline is Dr. Dean used it in the past, but not used nowadays. The other two have got selected in suppression, particularly lowering the endometriosis implant, particularly epithelial and stromal effect site, and they've got a reduction of TNF-alpha and other interleukins. The native products like epigallocatechin gallate, nothing but green tea. The other one is palmito oil, ethanolamide, and 7-oil natural components. They're all anti-aging, anti-antigenic, anti-inflammatory, and they all have that the cause might cause the reduction of the size of endometrioma and all these things. Then comes the holistic and alternative medicines. All these things may affect at molecular level, like herbal therapy, acupuncture, traditional Chinese medicine, this behavioral, cognitive behavioral therapy, diet and exercise, and all of those things. So the last part of my lecture is experimental therapy in autoendometriosis research, where I had the chance to learn it from a very good laboratory there in the University of British Columbia, a pain endometriosis pain lab in Vancouver, Canada, last year. And these are the young talents, young scientists who taught me a lot of these things. So experimental therapy, there are 4 areas. Number 1 is cell therapy. There are 4 sources. One is induced pluripotent stem cell. Second one is autologous stem cell in the form of menstrual or bone marrow derived stem cells. Those are being injected to ovaries. And third one is adipose derived stem cells along with the derived conditioned medium. And last one is reprogrammed macrophages, which acts on M1 and reverts to M2. The gene therapy in research, they have got adrenovector gene therapy, then several microRNAs, particularly microRNA LET7B and LET-C, LET7B and of LET-C, they have got definite impact. They reduce the histologic changes of endometriosis, and then comes some areas of alternate endometriosis researches. There are at least 107 microRNAs, microRNAs are there in endometriosis, and saliva test of endometriosis in therapeutics is coming up in a great way. We all know the Greek endo test by which you can do the diagnosis, earliest diagnosis with 97% accuracy, but the prediction of treatment response, that is individualization of the treatment, is possible by knowing the subtypes of endometriosis, and by that we can make the treatment plan before the clinical appearance of those particular disease, particularly on pain, the progesterone responsiveness and others, the need for surgery, and the prediction that is being assumed, or you can judge it well ahead before the girl get married or not. And it's a long process, very long process, DNA extraction, microenvironment, and all these things. I'm just skipping those things. These are the DNA extraction kit and optimization, and then various other things. There are 7 steps of DNA extraction, and then analysis and all these things. And this is the result of the PCR, post-PCR plate read. I'm not detailing here. The 4 results easily come out. One is the homozygous allele 1 and homozygous for allele 2. Third one is heterozygous, or fourth one is no template control. What you want to tell, then we put up in this chart and not detailing them. And the intention is to see how much NGH is there, which cause increase in nerve multiple density, which is the cause of dysmenorrhea and other pain, dyspareunia, dysphagia, and all. Then comes co-culture, which is primarily a 2D research model to produce a complex multicellular environment in endometriotic regions, particularly one component is endometrial epithelial cells, stromal cells, macrophages or peritoneal cells, and other part or neurons. And then always there is a crosstalk between these cells and the other compartment we do keep the therapeutic agents just to see what happens to this co-culture. this endocell and even co-culture as one area I could learn a little bit. It shows how much there is how much is the increase of nerve growth factor and the nerve bundle branch. And when that is so, in clinics, you can use anti-NGF drugs like tanezumab, sacituzumab, and turanumab, which are available in USA. The other area, we all know by this time that endometriosis is a totally neuroinflammatory disease on at least in 80%, and their NGF is increased. And another drug is anakinra, which is an immunosuppressant might be of help. And these are the various figures of focal
the semi-truots, and these are the different sites. Then organoids and co-culture system, we are used to see the histological sites of endometriosis and immunochemistry sites as highlighted by Ramani Devi and all these things. But I want to talk about endometrial epithelial organoids, which are novel endometrial things. And this is the 3D reconstruction of the patient-derived endometrial epithelial cells. You can see the green area and the stromal cells on the culture within 3D hydrogel matrix. And we can see fertile organoids and infertile organoids as well. I'm skipping this slide. The latest research is endo and neuron co-culture, which directly addresses the neuroinflammatory response, the neurogenic inflammatory potential that drives the debilitating pain. And you can see the organ on chip we can put up and become the truly personalized medicine, which is the need of the day. So, personalized medicine, truly personalized medicine with personalized drug therapy is the need of the day, particularly for refractory and drug resistant endometriosis pain. In conclusion, I would like to say that OG is not the last word. And so, no drug can effectively manage endometriosis associated pain and infertility simultaneously. Personalized medicine might be the future. And at present, we are too far clinically from this ultra endometriotic researches. Thank you. Thank you very much for the kind words.
Thank you, Dr. Mitra, for that very comprehensive and panoramic overview. And we all agree that we are nowhere close to an ideal treatment for endometriosis. So we have to choose between what is available, considering the cost, the side effect, and the efficacy of the drug. So, any other questions or Ramni, is it possible to have anything on chat box? So otherwise.
Yeah, nothing is in the chat box.
Okay.
Okay. Anyway, sir has given a detailed insight about the future of management of endometriosis. That because no treatment for endometriosis is complete without personalized intervention. All medical managements are going to be contra-reproductive, and now they are trying to come out with some medical management which will not prevent fertility also. And I think he has gone extensively in detail regarding the recent updates now.
Precision medicine is the future,
yes.
as this.
And of course, adding up artificial intelligence, that is again coming up in a new way. To find out the personalized treatment, we need the addition of artificial intelligence also.
Thank you very much for giving me this opportunity. I've learned a lot. And shall we conclude here?
Yeah, no. Here we have a quiz program.
We have quiz. We have quiz.
Yeah.
Yes.
Harshini will be starting the quiz.
Good evening, ma'am. So now we'll go to the quiz session. Jignesh. Jignesh, Pallavi, you guys are there?
Yeah. You started.
Jignesh, please process.
Yes.
Okay. A 34-year-old woman presents with cyclic hematuria and flank pain. The most likely site of urogenital endometriosis is? A. Bladder, B. Urethra, C. Ureter, D. Kidney. Last 5 seconds. The answer is A. Bladder. Shall we move to the next question? Which of the following statements regarding ureteric endometriosis is true? A. Intrinsic disease is more common than extrinsic disease. B. It commonly presents with gross hematuria. C. It may be completely asymptomatic despite severe obstruction. D. Renal function is never affected. Last 5 seconds. The answer is
C.
C. It may be completely asymptomatic despite severe obstruction. Next question. A woman with deep infiltrating endometriosis is found to have left-sided hydroureteronephrosis. The most appropriate next investigation is A. Hysteroscopy, B. Intravenous pyelogram, C. Renal tract imaging with CT urography or MRI, D. Endometrial biopsy. Last 5 seconds. The answer is C. Renal tract imaging with CT urography or MRI. Next question. The preferred surgical treatment for extrinsic ureteric endometriosis causing obstruction without severe fibrosis is A. Nephrectomy, B. Erythrolysis, C. Urectorectomy with ileal conduit, D. Radical cystectomy. The last 5 seconds. The answer is B. Erythrolysis. Which of the following is the strongest indication for surgery in urinary tract endometriosis? A. Mild dysuria alone. B. Incidental bladder nodule on ultrasound. C. Hydronephrosis with risk of renal function loss. D. Dysmenorrhea responsive to medical therapy. Last 5 seconds. The answer is C. Hydronephrosis with risk of renal function loss. At present, which drug you prefer to manage moderate endometriosis? A. OCPs, B. GnRH analog, C. Dynagist, D. Oral GnRH antagonist. Last 5 seconds. The answer is C. Dynagist. Which medicines preserve fertility potential while treating endometriosis? A. Cabergoline, B. Statins, C. Pentoxifylline, D. All of the above, E. None of them. Last 5 seconds. The answer is D. All of the above. Holistic and alternative advice can be adjuvant therapy to any endomanagement. Your opinion. A. Never. B. Sometimes. C. Maybe as lifelong advice. Last 5 seconds. Yeah. The answer is C. Maybe lifelong advice. experimental therapies are supposed to impact endometriosis? A. Hormonal balance. B. Immunomodulation. C. Microenvironment change. D. All of the above. Last 5 seconds. D. All of the above. Which of the following statements regarding the use of add-back therapy with elagolix for prolonged management of endometriosis is most appropriate? A. Add-back therapy with elagolix is routinely recommended for all patients requiring long-term treatment. B. Add-back therapy with elagolix is not currently approved and should never be considered. C. Add-back therapy may be considered in selected patients requiring prolonged treatment with appropriate counseling regarding benefits, risk, and limited evidence. D. Add-back therapy completely eliminates the risk of recurrence and adverse effects. Last 5 seconds. Sorry. Add-back therapy may be considered in selected patients requiring prolonged treatment with appropriate counseling regarding benefits, risk, and limited evidence. The most widely accepted pathogenesis of scar endometriosis is A. Coelomic metaplasia, B. Lymphatic dissemination, C. Iatrogenic implantation of endometrial cells during surgery, D. Genetic mutation. Last 5 seconds. C. Iatrogenic implantation of endometrial cells during surgery. The average interval between cesarean section and presentation of scar endometriosis is A. Few weeks, B. 6 to 10 years, C. More than 20 years in all cases, D. Only after menopause. Last 5 seconds. The answer is B. 6 months to 10 years. Next question. Which of the following is considered the most important differential diagnosis of scar endometriosis? A. Incisional hernia, B. Abdominal wall abscess, C. Suture granuloma, D. All of the above. Last 5 seconds. The answer is D. All of the above. During surgical excision of scar endometriosis, involvement of which structure may necessitate mesh repair? A. Skin only, B. Subcutaneous tissue only, C. Rectus sheath and abdominal wall musculature, D. Peritoneum only. Last 5 seconds. Rectus sheath and abdominal wall musculature. A 32-year-old woman presents with cyclical pain and 3 centimeter tender nodule in her phalangeal scar 4 years after cesarean delivery. Ultrasound suggests scar endometriosis. What is the most appropriate management? A. Empirical antibiotics. B. Fine needle aspiration only. C. GnRH agonist for 6 months as definitive treatment. D. Wide local excision with histopathological examination. D. Wide local excision with histopathological examination. Women with endometriosis have the strongest association with which ovarian cancer subtypes? A. High-grade serous and Brenner tumor. B. Clear cell and endometrioid carcinoma. C. Dysgerminoma and yolk cell tumors. D. Mucinous and borderline tumors. Last 5 seconds. The answer is clear cell and endometrioid carcinomas. Which gene mutation is most frequently identified in endometriosis-associated ovarian cancer? BRCA1, KRAS, ARIDA1A, and DAPC. The answer, last 5 seconds, sorry. And the answer is C, ARID1A. Next question. The lifetime risk of ovarian cancer in women with endometriosis is markedly increased, greater than 20%, slightly increased compared to the general population, C, unchanged, D, decreased. Last 5 seconds. The answer is slightly increased compared to the general population. Which of the following features in an ovarian endometrioma should raise suspicion for malignant transformation? A, homogeneous ground glass appearance. B, stable cyst size over years. C, solid papillary projections within the cyst. D, unilateral pain during menstruation. The answer is solid papillary projections within the cyst. Endometriosis-associated ovarian cancer is most commonly diagnosed in A, adolescent, B, reproductive age women only, C, perimenopausal and postmenopausal women, D, pregnant women. The last 5 seconds. Perimenopausal and postmenopausal women. Thank you. Can we have the... So Sivaranjani has got the first rank, and Salil Barsod the second, Swati Gupta the third, Dr. Mangala Gauri, and the next is Anju Chabra. Congratulations.
Sir, welcome Sanjeev Kurk, sir. I could see you.
Achha, no, I was there off and on because
Yeah. Okay, sir.
the operation theatre,
Okay.
therefore I missed. I just wanted to ask you, madam, one thing. The thing is, there was a discussion about you cannot have both. That means treatment of endometriosis as well as fertility. But then what about
No,
dydrogesterone?
sir. See,
I think-
generally, medical management is contra-reproductive, but now we have more specific drugs which can promote fertility also. For example, we use gabapentin, dydrogesterone, and there is that epigalactoic acid, and then we have one more drug that is chlorindazole. All those things are all now upcoming drugs because so far we have been using only gabapentin and dydrogesterone for promoting fertility.
Dydrogesterone, yes. Yes.
So other
So
newer
they are
drugs
there.
are coming.
So, fine. So newer drugs are. But at the moment, dydrogesterone, it has been well known that it doesn't block
Dydrogesterone and
ovulation.
gabapentin well known.
But that's okay. Great.
Thank you, sir.
Enjoy.
I think we
Dr.
can come
Mitra's
to the end of
presentation
the-
was futuristic.
end of the program. And thank you, Harshini, for conducting the quiz in a very
Thank you
nice
so much,
manner.
ma'am.
Yeah. Thanks
Thank
for
you,
all the
ma'am, for giving me the
faculties who have
opportunity.
participated today. Okay.